So once we establish the diagnosis, our next step is really the risk stratification, because we are going to tailor the treatment based on that. And in myelofibrosis, over the past few years, there had been several models that had evolved in risk stratification. Some of them are purely clinical, and some of the newer models incorporate some of the molecular and genetic material within the risk stratification. The classical models had been the IPSS, the International Prognostic Scoring System, or the dynamic IPSS, or the dynamic IPSS plus. And all of those will weigh on clinical factors such as the patient age, the anemia, the leukocytosis, presence of blast, constitutional symptoms. And some of them, in addition, like the DIPS, will allow for, the more weighing on the anemia, the blood cell transfusion, and the DIPS plus will account for like the thrombocytopenia as well as the karyotype. And we can divide patients into generally 4 risk groups, from low, intermediate 1, intermediate 2 to high risk. And the median survival varies according to those risk groups, from somewhere between 1 to 2 years for somebody who's labeled as a high risk to someone that have a median overall survival exceeding 10 years if they are low risk. So if we think of our patient, she's above age of 65, she's anemic, have leukocytosis, some constitutional symptoms, and the platelets are below 100. So she's definitely going to be a higher risk, whether we're using the IPSS or the DIPS plus. In certain cases also, as I mentioned, nowadays, we have some molecular models. There is the genetically inspired prognostic scoring system, or the MIPSS70, that had evolved particularly to allow risk stratification for patients we are considering for allogeneic stem cell transplant, because it's geared for those patients at the age that we think of transplant. It does not count the age as a risk factor. And it incorporates presence of molecular mutations, whether the patients have karyotype mutation or not, other high-risk mutations defined by presence of ASXL1, EZH2, SRSF2, or IDH1 and IDH2. And the newer version of it includes actually also the U2AF mutation as well. So based on clinical variables and molecular variables, we will put the patients in 1 out of 3 risk groups, the low, intermediate, or high, and the survival obviously will vary based on that group. And if we think of our patient here again, she probably will going to be high risk with the clinical variables and incorporating the absence of the karyotype mutation and the bone marrow fibrosis. There is another model that's used mostly or primarily for patients for post-ET or post-PV myelofibrosis. This is the MYSEC prognostic model that was particularly developed in a cohort of patients that had secondary myelofibrosis. So this is myelofibrosis evolved from either essential thrombocythemia or polycythemia vera. And we see here the variables used there are the age, hemoglobin, platelets, presence of circulating blast, the calreticulin mutation status, as well as constitutional symptoms. And we can divide patients into 4 groups based on that. And this model is available online, and one can plug in the numbers and see the outcome for the patients nicely with that model.